Hey there, before we get started, I wanted to share that we will be talking about uterine rupture, fetal demise, and maternal mortality in today's episode. Please consider this when deciding if and when you will listen to this podcast. Hello, and welcome to the VBAC Facts podcast. I'm Jen Camel, VBAC Facts founder. And since 2007, our focus has been to provide accurate and objective information on vaginal birth after cesarean and repeat cesarean to parents, professionals, policymakers in the court, so all decisions can be informed, ethical, and just. And the specific purpose of this podcast is to show you what is possible relative to VBAC. And we do that by sharing birth stories, the medical evidence, court cases, and also advocacy victories, people who are able to change hospital policy. So if you have a story like that you'd like to share, go to vbacfacts.com/podcast and submit your story. I would love to have you join our mission to show people what is possible so everyone has access to respectful healthcare even after a cesarean. Okay, so today we're talking about VBAC myths. And it was really fun preparing for this because I sat down yesterday and probably wrote down about 30 myths myself. And then I emailed my list and I did a couple social media posts. Some of you awesome readers came through with some incredible myths that I had completely missed. And there are so many, right? So it'll be interesting to see how the timing of this episode plays out. Is this going to be another two-parter, or are we going to be able to get it all in 1 hour? Or maybe it'll just be a little extra long episode. Who knows? So let's go ahead and get started. So before I jump into the myths, I just wanted to share some basic information about VBAC to create a platform of accurate information upon which we can build. So here are some basic facts and statistics about VBAC. So first and foremost, VBAC is a safe, reasonable, and evidence-based choice. I know that might be shocking for so many of you to hear, but it is true. It really is true. And as you listen to this podcast and as you learn more about what national guidelines says and what the medical evidence says, and when we talk about the risks and benefits of VBAC versus elective repeat cesarean section, you'll see that both options have risks and benefits, and there are so many different things that go into that decision-making process. Okay, another basic fact. The risks associated with VBAC are low, and just like a repeat cesarean, most people will birth their baby with no complications. And I think that's also a big surprise because I think a lot of people think that if you have a repeat cesarean, you have a high rate of complications. If you have a planned VBAC, you have a high rate of complications. And the reality is with both modes of delivery, most babies and mothers are born completely healthy and no complications. So I think that's a big thing to keep in mind. In both arenas, the complication rate is low. You're just talking about different kinds of complications, and especially different kinds of complications as we have more prior repeat cesareans. Here's a fact that may surprise you. National organizations, including in the US and around the world, support VBAC as an option, as well as organizations like the National Institutes of Health. And not only support, but they encourage access to VBAC. And that is important to hear because I think a lot of people think, well, VBAC is alternative, right? VBAC is something that other people do, maybe hippies do, or people who don't really know what the evidence says, people who value a birth experience over a live baby. These are all the things I've heard from people who say VBAC isn't for me. So it's important for people to know VBAC is a mainstream option. It is supported by national guidelines. It's supported by the medical evidence. I really love this quote from the National Institutes of Health from their 2010 VBAC conference. Quote, VBAC is a reasonable and safe choice for the majority of women with a prior cesarean. Moreover, there is emerging evidence of serious harms relating to multiple cesareans. The majority of women who labor after a cesarean will have a VBAC, and they and their infants will be healthy. However, there is a minority of women who will suffer serious adverse consequences of both planned VBAC and elective repeat cesarean delivery, end quote. And that is really the summation of the research on VBAC. I mean, if you wanted to boil everything we know down to just a few sentences, that would be it. And this is why no major medical organization supports the idea that a prior cesarean is a reason for a repeat cesarean. Now, I know this might surprise a lot of you, especially those of you whose provider has recommended a repeat cesarean. The reality is a repeat cesarean is indicated in specific situations, but the tricky part is that a lot of providers recommend a repeat cesarean for everyone in their clientele, regardless of the clinical circumstance. So you could be the best candidate in the world for a VBAC. Your predicted odds could be extremely high. Your clinical history and your current medical conditions could be that the likelihood of you having a VBAC is substantial, and yet they would still recommend a repeat cesarean. So that's the thing. So that's why it's always important to ask, why are you recommending a repeat cesarean? And then when you have a solid idea of what the facts are relative to VBAC, when your clinician replies to you, you're able to put their reply through your filter that is based on the medical evidence. And you're able to sit there and have a little BS detector go off or not. Because sometimes, absolutely, there are reasons why we have cesareans. Cesareans can be life-saving. And also, cesareans are massively overused in the US, and the high rate of repeat cesareans in the absence of labor is one of those things that drives the total cesarean rate. Okay, another basic fact that's important for everyone to keep in mind. The risks of VBAC are often exaggerated, and the risks of cesareans are minimized. And I see this all the time when I talk to parents, and I say, okay, so what did your provider tell you about VBAC? And they list all the risks. Okay, and what did your provider tell you about repeat cesareans? And most commonly, they're told a repeat cesarean is totally safe and they'll be fine. So let's look at that. When someone is given one option, of which the only thing that's associated with it is risk, and then they're given another option, and that option is presented to them as completely safe, I mean, of course people would choose a repeat cesarean, right? When that is what is presented to them. But we always have to remember, every option has risks and benefits. And if your provider is acting like VBAC has a lot of risks and cesarean is risk-free, you aren't able to make an informed decision. You really aren't able to consent to that cesarean because you aren't given the accurate information. Another basic fact that I think everyone should know. Everyone is a candidate for VBAC. And I say that because it's true. And even ACOG says there are no universal mandates. So people say, well, what if someone has a prior classical cesarean? Then they're not a candidate, right? Actually, incorrect. Because even ACOG says if someone who is otherwise not considered a candidate and they include a prior classical cesarean in that grouping, if that person arrives at the hospital and they're in labor, the provider and the parent together may judge, you know what, why don't we continue with labor and see how this plays out? I will be talking about classical cesareans, the evidence that we have in the future on the podcast, but in the meantime, I do have an article up on the website. If you go to VBACfacts.com and just search classical cesarean, it'll pop right up. And I have two articles, one that talks about the evidence on the uterine rupture rate associated with classical cesareans. And then there's a second article about how do we contextualize that information when we're talking to patients. So both really great resources. Another fundamental fact. Okay, so we're still getting through the facts before we even get into the myths, right? But another fundamental fact, and I want to ask you actually, okay? I want you to think for a moment. What does ACOG say about VBAC after more than one cesarean? How about more than 2 cesareans? What do you think ACOG says? Okay, hold that number in your head as I tell you that ACOG does not provide an upper limit on the number of prior cesareans. They don't. Check out episodes 3 and 4 of the podcast, and that's where I go through ACOG's VBAC guidelines, and we talk about that more in depth. And I will be doing episodes on vaginal birth after 2 cesareans and vaginal birth after 3 or more cesareans in the future. In the meantime, again, we have articles on those topics up on the website. So go check that out. There's so much good stuff up on the website. And really what I'm doing during this initial phase of the podcast is I'm going through the most important posts that I have up there that's summarizing the evidence, and I'm turning those into podcast episodes. So that way I can reach the audience who prefers podcasts as opposed to reading an article on a website. Okay. So that's important for you to hear. ACOG does not provide an upper limit because I've also heard from clinicians, well, ACOG says you can't have a VBAC after 3 or more cesareans. ACOG does not say that. So this again is another example of how there is this conventional wisdom about VBAC and conventional wisdom about what ACOG says, that when you actually look at what ACOG says, it doesn't hold up. So that's really why when you hear someone say, well, ACOG says, go check out episodes 3 and 4 of the VBAC Facts podcast and see, is that what ACOG says? Because I have to tell you, 9 times out of 10, it's probably inaccurate. Here's another one. ACOG maintains that people have the right to make their own medical decisions, including in situations of elevated risk. I hear from a lot of parents, well, my doctor won't let me plan a VBAC. And the thing is that this decision is yours. This is your body. This is your baby. And the complications that you may or may not experience either during a planned VBAC or repeat cesarean will happen in your body. So it is your right to make that decision. It's not about someone else letting you, because you are not a child. You are a grown woman who has the right to make your own medical decisions. So the idea of a grown woman saying they won't let me, stand in your power. Learn the facts. Find your voice and advocate for yourself, because I'm telling you, when you have that baby, your baby's going to need you to advocate for them. You are entering into the wondrous world of parenthood, and those children are going to need someone to advocate for them, someone to protect them, someone to stand between them and danger. And that person, dear parent, dear mother, is you. So now is the time to tap into that power. And when you hear someone say, my doctor won't let me, this is the time for us to remind each other of how powerful we are, right? We don't need to wait for someone's permission, because this is our right to make our own medical decisions. Consider any other area of medicine. Are we waiting for permission? No. It's about risks and benefits. It's about options. It's about informed decision-making. So the whole idea of my doctor won't let me, let's reframe that into I have the power and it's not your place to tell me what I am and am not allowed to do. Okay. Another fact, it's especially important for parents to have access to VBAC after one cesarean. And that's because after they have that second cesarean, the likelihood of them having a VBAC after 2 or more cesareans dramatically decreases. And again, that depends on where you live around the world or in the US, what kind of providers you have available to you. Some communities have spectacular providers that attend vaginal birth after 2 cesareans. And I'll be highlighting stories. We'll be having some stories here on the podcast of people who had hospital vaginal birth after 2 cesareans, because I want people to know, I want parents and clinicians, policymakers, and the court to know, vaginal birth after 2 or more cesareans happens here in the US, because I have heard so many clinicians tell parents, no one does that. And they say that because it's a way of making it seem like what you want isn't reasonable and no one's doing it. And the reality is it's absolutely happening. It is uncommon, but also ACOG supports that option and the medical evidence supports that option. And especially if you want more than 2 children, having vaginal births and avoiding repeat cesareans is absolutely the healthier thing in the long term. And I say that because of the risk of placenta accreta. And you can go to vbacfacts.com/accreta, ACCRETA. And I actually had to type that out because sometimes it's hard for me to spell things in my own head. And you can see an article I wrote for Lamaze's Science and Sensibility blog all about placenta accreta. So we have to remember each prior cesarean increases the risk of complications like placenta accreta increta and percreta, placenta previa, hysterectomy, excessive bleeding, as well as ICU admissions, blood transfusions, a whole host of complications that have implications for future fertility. So repeat cesareans are not benign. And so that's the thing we have to keep in mind. Remember, everything has risks and benefits. Okay, and then another fundamental thing is that the VBAC calculator is problematic, and we have a whole episode on that. It's episode 6, and we dive into the VBAC calculator. I highly encourage you, if you are a clinician who uses the VBAC calculator, if you are in a practice with clinicians who use VBAC calculators, if your client's clinician uses a VBAC calculator, or if you are a parent who's had a prior cesarean and your provider has pulled out the calculator for you, and it gives you a 30% odds, listen to that podcast and then share it with those clinicians, because that's how we get accurate information out there. Okay, so let's dive into the myths. And I really wanted to start with an email I received today from a reader. And so Lee from Nebraska wrote me this email, and it really touched my heart, and they gave me permission to share it with you. I want to start with this email because it really encapsulates the journey that so many people have, and all the myths that she came up against and everything she broke through in order to have her hospital vaginal birth after 2 cesareans. And who knows? I've asked her if she wants to be on the podcast. Maybe she'll join us. So she says, "Hello, Jen. I'm not sure if you remember, but I emailed you last May with fears that my last chance for a vaginal birth after 2 cesareans was slipping away after I learned that the surgical notes from my second cesarean noted a defect in the uterine scar from my first cesarean, and one of the only providers who would still accept me as a patient wanted to measure scar thickness via ultrasound to determine VBAC candidacy." Now remember, measuring uterine thickness via ultrasound is not evidence-based. We do not have solid evidence, and we can do a whole podcast on that topic if people are interested, but it's not evidence-based. So back to her email. She says, "It's kind of a long story, and the entire pregnancy was a wild ride, but I had a vaginal birth after 2 cesareans on July 18th, 2024. The work you do was a large factor. It's hard to find the words to convey my gratitude, which is why I haven't emailed you until now. There is so much more to say. However, I want to at least reply to your email at this time with some things that were kind of the flip side of myths, since they, despite what some may say, do not mean someone can't have a VBAC. I know this because all of them happened to me, and I still had a VBAC after 2 cesareans. So these are all the things she listed. You can have a VBAC in a hospital, even after 2 cesareans, even if you've never had a vaginal birth, even with white coat hypertension, even with a history of severe preeclampsia, even with a history of fetal macrosomia, even if your hospital has a VBAC ban, even if you live in a rural area, even if the nearest VBAC supportive hospital and provider are 200 miles away, even if you have to switch to a different team of care providers for each trimester due to circumstances beyond your control, even if you have a, quote, high-risk pregnancy, even if you are, quote, advanced maternal age, even if the surgical records from your second cesarean note a, quote, defect in the uterine scar from your first cesarean, even if you plan to wait for labor to begin on its own in the absence of complications, even if you develop preeclampsia, even if you end up needing an induction." It's a powerful list. So she continues, "Here are some myths that doctors have repeated to me at 2 different facilities. ACOG says that we can't offer VBAC because we don't have 24-hour anesthesia on site. Our hospital can't do VBACs because we don't have a NICU." Okay, I just want to pause. There's so much in her email. ACOG does not say either of those things. So if you think that is what ACOG says, again, you can go back to episodes 3 and 4 of the podcast, and I go through ACOG's VBAC guidelines, but ACOG does not say that. Hospitals do not need to have 24-hour anesthesia on site to offer VBAC, and hospitals don't need a NICU in order to offer VBAC. In fact, what ACOG says is that every level 1 hospital in the US should be offering VBAC. So what that means is any hospital that has a labor and delivery unit in the US should offer VBAC. There is no reason why you cannot offer VBAC. If you have L&D and you have emergency protocols in place, which all hospitals do, right? Or at least they should. And if you don't, I urge you to go to the California Quality Maternal Care Collaborative, CMQCC, and download their toolkits. Their toolkits will help you mobilize in the event of a whole host of obstetrical complications that lead to maternal death, including obstetric hemorrhage. So if that is something you don't have in place, go there now. Okay, pause the podcast, go there, download it, and start implementing that, because that's something you can do right now that will improve outcomes, not only in your facility for first-time parents, but for people who plan a VBAC and for people who need a cesarean for whatever reason. And what we have found in the state of California is that through the implementation of these toolkits, they are able to reduce maternal mortality and morbidity. That is the power of preparation. So rather than saying, we can't offer VBAC because we don't have 24/7 anesthesia, or we can't offer VBAC because we don't have a NICU, I want hospitals to consider not only is that not true, but what can you do right now to improve outcomes for everyone? And one thing you can do right now is improve your response and standardize your response to various obstetrical complications. Okay, so let's go back to her email. She says, also, it is a myth that all hospitals providers who say they offer VBAC are actually supportive of VBAC. She says, looking at whether their patients actually end up having VBACs show us the truth. And I just want to pause and say, yes, absolutely. I mean, there are providers who say, oh yeah, I'm supportive of VBAC, but the asterisk beside that is, I support a VBAC if you have a baby of a certain size, at a certain gestational age, and your labor is a certain length. Oh, there's my dog. Don't you love it when your dog busts in when you're recording a podcast? But you know what? Look, he sat right behind me, so you can't even see him. That's so funny. So that's also called like a Cinderella VBAC, right? So someone who meets all these qualifications, including, let's not forget, by a certain gestational age, and typically that's like 39 or 40 weeks. And oops, if you're still pregnant by that point, you, quote, have to have a cesarean. That's not true. So this is why it's so important to first know the facts, and second, ask your provider very distinct questions. And you can go to vbacfacts.com/questions and see what questions I recommend. Okay, let's continue. She also says, I was initially surprised to learn that not all uterine ruptures result in death, even if they aren't caught immediately. I think a lot of people are under the impression that a uterine rupture always results in the death of the baby, mom, or both. I have a whole continuing education training on monitoring during a planned labor after a cesarean within VBAC Facts professional membership. And within that is a whole module on the timing of the diagnosis of the uterine rupture and perinatal mortality and morbidity. I am going to dive into that data just a little bit here because I think that's a common question that people have. Okay, let's go back to her email. I believe that some of the most important factors in obtaining a VBAC are understanding the facts and true risks for yourself, so important, who you choose as your provider, where you choose to birth, like which hospital, and who you choose for your support team, a doula, etc. And then she said, thank you for everything you do. Your work has made a tangible difference in my life that is difficult to communicate in a succinct manner. With love from Nebraska. I love emails like this. So I want to dive more into the statement she made about not all uterine ruptures resulting in death, because I think that is a question that a lot of parents have. I think that's a question a lot of clinicians have. And of course, the number one thing that's going to impact that outcome with a uterine rupture is how quickly it is diagnosed and how quickly the baby can be born, either vaginally if birth is imminent or an emergency cesarean. Now, I want to share what ACOG says in terms of perinatal mortality. And I have a whole article up on the website on this topic. where we dive into what ACOG says in terms of perinatal morbidity and mortality relative to planned VBAC, which they call trial of labor, versus elective repeat cesarean section. Let's define what perinatal mortality means. So perinatal mortality is one of the ways that we can measure mortality rates for the baby. And so that's looking at fetal deaths after 20 weeks gestation, all the way through to deaths that occur during labor, and then infant deaths 28 days postpartum or 28 days of life. Okay, so that's what perinatal mortality includes. And so ACOG says that the rate of perinatal mortality associated with planned VBAC is 0.13%, which translates to 1 in 769 planned VBACs, or 13 perinatal mortalities per 10,000 planned VBACs. Now, I like to give statistics in those different numbers, and that's because numbers hit people differently, right? Like for some people, 0.13%, they're like, oh, I totally get that. That makes sense. Other people, it's helpful to hear 1 in 769. And I also like the 13 per 10,000 because a lot of studies report their outcomes that way. And so I'm going to give you a few numbers so this way we can easily compare them. Let's also remember that that number, that 0.13%, is for planned VBACs. So that includes everyone who labored after a cesarean and those who birthed vaginally who had a VBAC, and those who labored after a cesarean and ended up needing a repeat cesarean for whatever reason. So both of those outcomes are combined in the planned VBAC category. Now, the other thing to keep in mind is this 0.13% number is from the Guy's 2010 evidence report. And that was really the basis for the 2010 National Institutes of Health VBAC conference. Now, when you have data that's from 2010, that's from births that could have been the early aughts, even the late 1990s. So that data is a little bit old at this point, right? So, because now I'm recording this, it's 2025, that data is now at least 15 years old, probably closer to 20 years old. And so this 2017 study by O'Neill said, although an increased risk of neonatal death was found in women with a TOLAC, there was evidence in their study of a cohort effect, which showed this increased odds disappearing over time. And so advances in modern healthcare, including improved monitoring and earlier detection of underlying pregnancy complications, may explain the findings. And so one of the things that I was looking for is that I was looking for more recent data on perinatal mortality associated with uterine rupture, specifically after a cesarean, right? Because we don't want to look at perinatal mortality with uterine rupture with someone who's never had a cesarean. And so when we look at perinatal mortality for uterine rupture, those studies often pop up. So it's really important when you're reading the research to consider who are they studying? Who are they including in this study? So a 2018 study by Vandenbergen of 627 verified uterine ruptures across 9 European countries found the rate of perinatal mortality among planned VBACs to be 3.2 per 10,000. And so they qualified the risk as extremely low. Now, they also looked at how likely was it for the baby to die if there was a uterine rupture. And they found that it was about 9%. So about 9% of uterine ruptures result in a baby dying. And so that's the same as 1 in 11 uterine ruptures, or 9 perinatal mortalities per 100 uterine ruptures, or 909 perinatal mortalities per 10,000 uterine ruptures. So I know that's a lot of numbers, but I provide those various numbers because, like I said, different numbers hit different people differently, and I'm looking for understanding and comprehension so that way people can see how the risks change with various scenarios. So I also want to share briefly the various factors at play when we're talking about uterine rupture-related perinatal mortality. 1, the size of the uterine rupture. Where is the uterine rupture on the uterus? How big is it? Is it interfering with a major blood vessel on the uterus? Where is the location of the uterine rupture relative to the placenta? Remember, the placenta is delivering blood and oxygen to the baby. If we disrupt blood delivery to the placenta, we are disrupting oxygen delivery to the baby. So if that uterine rupture is close to or underneath the placenta, it could dramatically impact oxygen delivery to the baby. Has the water been broken? Has the amniotic sac been broken? One of the things that we have found when we look at the research is those babies whose water has broken and thus they're able to go through the uterine rupture and into the abdominal cavity, those babies have the worst outcomes. So really, it's ideal when we're talking about people laboring after a cesarean to not artificially break the bag of waters. Let that occur naturally, because in the event of uterine rupture, it does provide a measure of protection. Now, the other thing, as I mentioned before, it's the time to diagnosis. So how much time elapses from when the uterine rupture occurs to when it's diagnosed, and also time to delivery. So the amount of time that goes from the time the uterine rupture occurs to when the baby is born, whether that is vaginally or via a repeat cesarean. So a lot of different things at play, right? And so that's why when we look at these overall rates, like a 9% risk of your baby dying in the event of a uterine rupture, we can see here. What did I just name? I named 1, 2, 3, 4, 5, 6, 7. 7 different factors that can impact how that uterine rupture plays out. So in an individual situation, that 9% number may be substantially higher. It might be substantially lower. Now, the other thing she had mentioned is that how she and many people believe that if you have a uterine rupture, then that surely results in a maternal death. And that's another thing that the Guy's study looked at. They looked at the rate of maternal mortality, and they could not find one person in the 8 studies that they looked at on maternal mortality, one mother, one birthing parent who died as a result of a uterine rupture. So it's very rare. However, it surely happens, right? But it's very rare. And again, those various factors that I mentioned that would also play a role in maternal mortality. Because while that blood delivery to the fetus impacts how oxygenated they are, how much oxygen they're receiving, that bleeding also affects the mother or birthing parent in terms of obstetric hemorrhage. One of the statistics that the American College of OBGYNs shares in their 2019 VBAC guidelines is the rate of maternal mortality among those who plan an elective repeat cesarean section and those who plan a trial of labor. And remember, trial of labor is another word for planned VBAC, and both trial of labor and planned VBAC include everyone who labored after a cesarean, those who birthed vaginally, and those who had a repeat cesarean during their labor. So what does ACOG say? Well, ACOG says that the risk of maternal mortality is 5 times higher with an elective repeat cesarean section than with a planned VBAC. And so as a result of that, I actually have one of my pinned posts right now on Instagram is a post that reads, "It is unethical to deny someone planned VBAC when the risk of maternal death is 5 times higher with an elective repeat cesarean section." Now, what is the absolute risk? Well, the absolute risk of maternal death during a planned VBAC is 0.0019%. Okay, so that's a really small number, but that's the same as about 1 maternal mortalities in 52,600 planned VBACs. So it's a really low risk, right? So did you have any idea the risk was that low? So now let's think about what is the risk of maternal death with an elective repeat cesarean section. It's 0.0096%, or the same as 1 in 10,000. Now, both of these numbers are really small, but the risk of maternal death is 5 times higher with a repeat cesarean. And this is why when pregnant people are threatened with, well, you could die if you plan a VBAC, it really falls flat. But statements like that are incredibly successful in coercing people into elective in quotes, repeat cesarean, as well as eroding patient autonomy and any trust when the woman or birthing person learns the facts. In that thread, I had a reader ask me, well, does this apply to emergency cesareans? And the answer is yes, because those statistics are included in the planned VBAC category. Because remember, Planned VBAC means anyone who labored after a cesarean. And so one thing to consider is, why did that emergency cesarean occur? Was it from preeclampsia? Was it from abruption? Is it something that is likely to happen again or unlikely to happen again? And what I found with this post is that a lot of people got really upset. And so I started to talk about it in a little bit of a different way. And I said, it would also be unethical for someone to be forced to have a VBAC because of the risk of uterine rupture. But that's not what we see happening in hospitals. Hospitals are denying people VBACs and leading them to believe that repeat cesareans are the only option allowed by hospital policy. People are even forced or coerced into repeat cesareans by exaggerating the risks of VBAC and remaining silent on the risks of repeat cesareans. Now, to be clear, it would be unethical to force anyone into any medical procedure because everything has risks. If you want to learn more, I invite you to learn more with me. So I have continuing education. It's the most comprehensive continuing education program geared towards VBAC for professionals. And it is called the VBACs Professional Membership. You can go to VBACFacts.com/membership to learn more. We have continuing education trainings. I referenced several of those today. We have grand rounds. We have patient handouts. We have expert interviews. It is an incredible resource. And if you are passionate about VBAC and you want to provide the best information and support to your patients who've had a prior cesarean, I welcome you to join me. If you've had a cesarean and you're evaluating your options for yourself, you can go to VBACFacts.com/courses and learn more about our program, The Truth About VBAC for Families. It's everything I wish I knew when I was pregnant after my cesarean that was over 18 years ago now, and the most important things that I've learned since. And I think that, just like how our reader from Nebraska mentioned today, information is power. Being able to navigate your options, you can't do that if you don't have the information. If you want to bring me out to your community and have a VBAC Facts training, you can learn more about that at VBACFacts.com/speaking. And in fact, I will be speaking at the WARM conference in Washington State this April 24th through 26th. I'll be presenting my 3-hour session called The VBAC Imperative: How to Improve VBAC Access and Outcomes While Decreasing Litigation Risk. Now, this program might sound familiar to you because I delivered a 1-hour version of this program to the Minnesota affiliate of the American Association of Nurse Midwives this past October in Minneapolis. And that was an incredible session, and 1 hour is just simply not enough. So we're going to do a 3-hour session. It's going to be in Washington State. Registration is not open yet, but I urge you to either join my email list or keep an eye at warmmidwives.com. So that way, when registration opens, you can secure your ticket. And if you're deciding to come, please send me an email because I would love to meet you in person at the conference. That would be incredible. Also, don't forget, I do offer policy and legal consulting, as well as consultations to professionals and parents. Okay, so we have another email from reader Heidi. I really appreciated this. She said, myths I've encountered this week alone. Uterine rupture risk increases daily after 40 weeks. False. And here's the thing. When a clinician says something like this, the next thing I would say is I would really love to read more about that. What study found that? And if there is a study that has found this, please share it with me. I would be more than happy to add it to the show notes. But the studies that I have read on uterine rupture by gestational age has not found a statistically significant increased risk beyond the estimated due date. And this is why the American College of OBGYN says going beyond the due date alone should not preclude VBAC. Okay, here's another myth that reader Heidi shared with us. The pelvis is a fixed shape that doesn't change, and therefore, once a cesarean for CPD, always a cesarean. Now, CPD describes a situation where the baby's head does not fit through the pelvis, right? And so she's saying that providers have said, well, if you had your cesarean for CPD, that means, the pelvis doesn't change shape. you'll always need a C-section. Okay, so every labor is different, and there are so many things that play into how an individual labor plays out. We have not only the pelvis, but we have the position of the baby, we have the psyche of the mother, we have the strength of contractions. There's a lot of different things that go into play. And say you had a cesarean for CPD, but you were relegated to the bed the whole time, right? You weren't allowed to move. And maybe your baby was posterior. Your next labor, your next pregnancy, baby isn't posterior. And you have freedom of movement. Just change one of those variables, you can have an entirely different outcome. Change two of those variables, you could have a dramatically different outcome. So that is absolutely a myth. She said, AKA, you'll never VBAC a baby bigger than your cesarean one that got stuck. Completely false for the exact same reasons, right? There are so many factors that go into how that birth plays out. So just because something happened in your prior delivery doesn't mean it's going to repeat. Another myth that reader Heidi shared, no induction allowed for VBAC, not even Pitocin. Absolutely false. I shared that in episodes 3 and 4. Pitocin and Foley catheter are options after a cesarean. And I think that is so important for people to hear because there are clinical scenarios where induction would be appropriate. And in those clinical scenarios, if induction is not an option, people either get to choose whether they are going to continue to remain pregnant with that complication or have a C-section. It's wonderful in those clinical scenarios for people to have the third option of choosing an induction. So, again, it's about options and risks and benefits. Another one that reader Heidi shared, so many variations on requiring spacing from cesarean to next pregnancy or birth. We have a whole article about that up on the website on birth intervals. And just here's the thumbnail. ACOG says short birth intervals are associated with lower VBAC odds, but ACOG does not say that short birth intervals are associated with an increased risk of uterine rupture. And of course, that's the thing that a lot of people are scared of, right? So go check out that article on the website. A final myth from reader Heidi. She says, regarding in vitro fertilization, she's heard technology in, technology out, meaning that all IVF pregnancies require induction and or cesarean and won't happen spontaneously. Okay, also a myth. Okay, so here we are about 40 minutes into the podcast. I still have so many myths to share with you. Okay, so let's just go through them. So VBAC myths, some of these I've already touched on, but I want to reiterate. VBAC is an alternative choice. Absolutely false. The risks of VBAC are minuscule or the risks of VBAC are excessive. I think both of these characterizations really fail to inform the public. It's not helpful to say something is minuscule or excessive. What's helpful is to talk about the actual rate of something occurring. And so that leads into another email this morning. And she said, what is the risk of uterine rupture really? That's a great question. So I love this one statistic that was published from the Landon 2004 study. And I appreciate it because he controlled for a variety of different things. So this number looks at people who had one prior low transverse cesarean, who were not induced or augmented, meaning they weren't given anything to start their labor or any drugs to artificially make their labor progress. And so just controlling for those few things. So we're looking at spontaneous labors after one prior low transverse cesarean, and their risk of uterine rupture was 0.4%. So that's the same as 1 in 240 planned VBACs. Now that statistic changes when we have labors that are augmented. So that means that labor began spontaneously, but someone was given a drug to make their labor progress more quickly. That drug is most commonly Pitocin. And so that increases the uterine rupture rate to 0.7%, or the same as 1 out of every 111 planned VBACs. Then we have the rate of uterine rupture induced. So in this study, they were induced with Pitocin and prostaglandins, and the overall rate of uterine rupture for those labors was 1%, or the same as 1 out of 100. Now, those are the big things that impact the risk of uterine rupture, whether your labor is spontaneous or not, and also the number of prior cesareans and the type of uterine scar you have. And so if you have one prior low transverse cesarean and you go into labor spontaneously, you are at the lowest risk of uterine rupture. Now, once we have more than one cesarean, once we are induced or augmented, once we have, say, a high classical cesarean, those numbers change. And I'll have subsequent podcasts on those topics. We also already have articles up on the website, so go check it out now. You don't have to wait for the podcast to come out. You can go get that information right now. Here's another myth. They have to go into spontaneous labor by 40 weeks or they automatically need a repeat cesarean because the uterine rupture risk is higher. So again, this is similar to the other myth that we read earlier, but some of these myths are expressed in different ways, and I think it's really helpful to talk about all the different ways that these myths are expressed because I really want this to be the VBAC myth-busting podcast episode to end all episodes, right? Like I would love to get every single, because that's me, I'm comprehensive, right? So I want to have every single myth in here, and I feel like we've got them, but if there is a myth that we did not cover, let me know. Okay, leave it in the comments. I want to know the myth that we did not cover because I want to highlight it for people so they know it's inaccurate. Another variation of that is in order for VBACs to be safe, birth must take place before 40 weeks. That's not true. If their cervix isn't changing during prenatal exams, they're less likely to go into labor for a successful VBAC. Absolutely false. And so this myth can be used to make people think, oh, your body's not going to go into labor anyways, just schedule a repeat cesarean. Whereas the reality is dilation it's not a predictor of when you're going to go into labor. Someone can walk around at 4 centimeters for 2 weeks and then go into labor. Someone can be high and tight, meaning their cervix is high and it's not dilated at all, and they can go into labor that night and have a really quick birth. So we are not computers, right? So we're human beings, and how things play out can vary greatly from person to person. So don't believe in this whole well, it has to fit this standard. It has to look like this. It doesn't. Oh, here's another really good one from reader Cynthia. She said, all VBACs are more dangerous than a first-time parent giving birth. Yeah, absolutely. And in fact, one of the statistics I share in The Truth About VBAC for Professionals and The Truth About VBAC for Parents is one study found that the rate of, I think it was perinatal mortality, was the same in a vaginal birth after one cesarean as it was for a first-time parent who didn't have a prior cesarean. So again, we have this conventional wisdom. Many people have this concept of safety and this concept of, well, VBAC is more dangerous. And the reality is that's just not, when we look at the research, it's just not true. Repeat cesareans have no complications. That's another common myth. And I touched on that earlier, so I'm just going to keep on going. This is one I hear. No one attends VBAC in your community. I've even heard providers say there's no one in the U.S. who will attend a vaginal birth after 2 cesareans. And I think it's really bold to make a statement like that because that implies that somehow you are aware of what happens in every single state of the country. And the reality is when we look at nationwide data, people are having vaginal birth after 2 cesareans. They're having it after 3 cesareans. They're having it after 4 cesareans. So that is absolutely happening. The concept that VBAC is dangerous, that is a myth. VBAC isn't evidence-based. That's a myth. Another myth, you can't have a VBAC if it's been less than 18 months since your last cesarean. Absolutely false. VBACs cannot happen unless a baby is measuring below a certain size. Absolutely false. You can't have a VBAC with a single layer suture. That is false. You can't have a VBAC if you are expecting twins. That is false. Reader Krista sent me this myth. If you've had an emergency cesarean, it's probably going to happen again and it rules you out from planning a VBAC. Absolutely false, because like we've talked about before, just because something happened in the first pregnancy or the second pregnancy, that is not a predictor of what is going to happen in the current pregnancy. Change a few variables, it can be completely different. You can't have a VBAC after more than one cesarean. Absolutely false. No one can force you to have a cesarean. Now, we have what's legal and right? That no one should be forcing you to have surgery. But then we have what happens. And we know that what is legal and right doesn't always line up with what actually happens in the real world. And coercion, physical force, that does happen. So it's important to remember you ultimately have the right to decide what happens to your body. And I think it's really important for professionals and providers to hold each other accountable. Okay, another myth. ACOG says facilities without 24/7 anesthesia are not allowed to offer VBAC. We already talked about that. Here's another one. You can't have a midwife-attended birth if you have a prior cesarean. Absolutely false. I mean, the reality is individual hospitals might have policies about midwives attending VBACs and forbidding them from attending VBACs. But just like any other birth, if a midwife is attending a birth in a hospital and there is a complication that occurs that requires a higher level of care, they call the obstetrician in. They dive into those clinical skills that they have to determine, is this a situation where I just need a consult? Is this a situation where the OB needs to come in? Is this a situation where we need to have a cesarean right now? So those same protocols come into play. And in some states, it is legal for midwives, either certified professional midwives, certified midwives, or certified nurse midwives, to attend VBACs in either the home or birth center setting. Another myth, not all hospitals are allowed to attend VBAC. You can't have a VBAC at a community hospital, or you need special training or resources to offer VBAC. So, as I said at the beginning of the podcast, ACOG says all level 1 hospitals across the U.S. should be offering VBAC. So, no, you don't need any special resources or training. If your hospital is prepared to perform an emergency cesarean, and if you have an L&D unit, your hospital does have protocols in place, you can attend VBAC. And if you don't have emergency protocols in place or you don't have standardized protocols in place, again, this is a moment to go to the California Maternal Quality Care Collaborative, the CMQCC, and download their toolkits and get that set up in your hospital because that will improve outcomes for everyone at your facility. Another myth is hospital policy can keep you from planning your VBAC. And our reader from Nebraska earlier mentioned this. Hospital policy is their policy, but their policy does not supersede your legal right to decline surgery. And we have to remember, that's what we're talking about, is declining surgery. And no one has the right to tell you, you have to have this surgery. That's not right. So another one, it's illegal to have a home or birth center VBAC. Now, that is based on the licensure laws in different states. And so different states may say, okay, so you're a midwife. Midwives can't attend someone's labor who's had a prior cesarean. But does that mean it is illegal, like they're going to arrest the birthing person if they have a home or birth center VBAC? The risk is on the midwife. The risk is not so much on the birthing person. But it's really important to be clear on that because when we hear that it's illegal to have a home or birth center VBAC, then that elicits a different set of thoughts than it's outside of the licensure of a midwife in some states to attend a home or birth center VBAC. Okay, the final myth I want to share is that VBAC is selfish. And I want to tell you something. How we birth our babies is morally neutral. There's not a good way to birth your baby and a bad way to birth your baby. Planning a VBAC or scheduling an elective repeat cesarean section, both of those choices are morally neutral. And I really love that language. I actually got that concept of morally neutral choices from Casey Davis. She's the author of How to Keep House While Drowning. Casey, if you're listening, love your book. Amazing book. And I really loved how she framed, and she was using that language relative to keeping your house clean. Keeping your house clean is morally neutral. This isn't good or bad. It just is. It's the same thing with VBAC and repeat cesarean. So, this whole that's not a real birth or you're not a real mom. I really urge all of us to think about how we would communicate this information if we were talking to our children, right? If your sweet child was pregnant, how would you talk to them? Would you tell them that they're not a real mom because their baby was born by cesarean? Would you act as if one way of having your baby was better than another? Would you lay that judgment on their heart? If not, I want you to talk to yourself the same way. And I want you to talk to other people, especially on the internet, the same way. We need more compassion and empathy and less judgment. And I think one really great way to ensure that that happens is before you say something to someone online, I want you to pause and think, would I speak this way to my child? Would I be this cruel? Would I be this mean? Or is there a way for me to either express what I want to express through the lens of empathy and compassion? Or is this a moment where I should not post anything at all? I've talked for years about my lofty goals that I have with my social media, and I have created, I should say, we collectively have created an incredible little corner of the internet where we talk about the facts, we talk about autonomy, we talk about responsibility, but there is no judgment because there are things that we can control and there are things that we can't control. So there's no judgment. These choices are morally neutral. So while you are on either your VBAC journey or while you're caring for patients, I want you to keep these myths in mind. And if you know someone who would benefit from this podcast, share it with them. That's what it's about. We want to show people what is possible. And don't forget to leave me a 5-star review. And until next time, I'm Jen Campbell, VBAC founder. And don't forget what we're about. Our mission here is to show people what is possible relative to VBAC. And since 2007, our focus has been to share accurate and objective information about vaginal birth after cesarean and repeat cesarean to parents, professionals, policymakers, and the court, so all decisions can be informed, ethical, and just. Until next time, take care, my friends.